Good evening, everybody. I'm Dr. Deepika Tikoo, and before I start, can you guys just give me a smiley or a thumbs up in the chat box so that I know that the screen is visible to you and I'm audible as such? Or just type a yes. Good evening, Campylobacter. All right, so I assume that yes. Thank you, Ajmal. Thank you so much. All right, audible and visible. Thank you so much. Thank you, Mithun. Thank you, Sam. So, all right. Without much ado, so what we are going to do today is we are going to discuss some previous year pharmacology questions and we are going to discuss points around them. Okay? So that's how we're going to go about it. And what I would want you to do is take active participation, and when I ask the question, so respond. It doesn't matter, you do not know, the participation is what is more important. Good evening, Abhirath. Good evening, everybody. Ashutosh, Abhirath, Mohit. Okay, so I want maximum participation because that encourages everybody in the room, and we will learn few more things if you do not know them already, and many of you appearing must be knowing many of these, just it is for revision only. So let's start. All right, so let's go to the first question for the day or for the evening as such. Now this is a graph which has been shown to you. So can you calculate the therapeutic index from this graph? Very quickly. Very good, very good. Awesome. Dr. Subham says 8. Yes. Others too? 8. Sam says 8. Awesome. Very good. Awesome. So we all know that the simple formula to remember the therapeutic index is 8888. Yes, 1 8 is enough. Okay, so this is style. That is a mnemonic that you should know. So it is loading dose 50. No, it is loading dose over the ED50. Sorry, lethal dose 50 over the ED50. So tile yaad rakho, if you remember the tile, so you won't forget what comes in the denominator and what comes in the numerator. Okay? So it's TILE. So the lethal dose in the 50% population, here it is 64. Okay? Because this is the response. 50% means 64 the dose here, and the effective dose here is 8. So this is the what you should remember about this, right? I hope that is clear to you now. So what does therapeutic index actually tell you? It tells you about the safety margin, right? It tells you about the safety margin. Now therapeutic index, the term we don't use in clinical settings. These are the terms which is used actually in the experimental, on the animals. So for humans or in the clinical settings, the term that we use is the therapeutic range. The therapeutic range is the term that we use, right? So these are the few important therapeutic ranges which have been asked previously, and these you can just know about them ki kya kya hai iske, the ranges which you do. First and foremost, very important is your digoxin. Okay, so digoxin 0.5 to 1.4 nanogram per ml. But because the toxicity usually comes when the levels go above 2. So even if your option is 0.5 to 2, that will also be correct. Agar option mein this is there, that will also be correct. So 0.5 to 2 will also be correct. So this is the digoxin levels. Then comes your lithium. Now lithium levels, you know that for acute and for maintenance, these are the two most important therapeutic ranges. Acute episode mein it is 0.8 to 1.2, and for maintenance it is 0.5 to 0.8. Again, the range can be asked as this one, 0.5 to 1.2. So you can mark that even. Whenever the levels go more than 4, if hemodialysis is asked, then we do the hemodialysis when the levels are greater than 4. Right? So that is another important thing to know. For phenytoin, it is 10 to 20. Theophylline 5 to 15 micrograms per ml. And for valproate, it is 550 to 100 micrograms per ml. These are the few important therapeutic ranges to know. Right? All right. Yeah, dialysis greater than 4. Yes, definitely. Now, coming to the next. So the next question is, what would happen to the elimination half-life and plasma concentration of a drug which follows the first order kinetics if the dose is doubled? This has been repeatedly asked in one way or the other, so very important to know about the first order and the zero order kinetics. Okay, Lubana says T half is the same. Okay, excellent. What about the plasma concentration? All right, constant directly proportional plasma concentration. So here what will happen? Directly proportional is right. Here what will happen? Yes, Mithun, exactly. So if the dose is double, yes, Campylobacter. This is also doubled. Yes, so you're right, the T half remains the same and the plasma concentration gets doubled. That is what the answer should be. So just a little recap of kinetics of elimination. So zero order में क्या होता है? A constant, yes, what? A constant amount or a fraction? Zero order. Is it constant amount or constant fraction in zero order? Dash. Very good. So constant amount in zero order. Yes. Fraction, because F first order starts with an F. So remember, constant fraction. A percentage of the drug is eliminated. Constant fraction, constant amount, right? Now, what happens, we have discussed here in the first order that in first order, your half-life remains constant and your plasma concentration is going to increase. So let's take the same in the zero order. What will happen to the half-life in zero order? Half-life in zero order. Yes, quickly, half-life in zero order. क्या होगा? Increase. Okay. It is proportional, yes. So it will change or it will not remain constant and it will be proportional to the plasma concentration. So half-life is not constant in zero order kinetics. Okay? The concentration will definitely change or increase. If you double the concentration or dono mein, it will be the same. But the main thing is the half-life. Half-life not constant in zero order. What about elimination? Elimination and clearance. Elimination and clearance. Okay, let's talk about the first order. What happens to elimination in the first order? Constant in zero. Constant in zero is what? Elimination or clearance? Different terms hai, theek hai? Elimination and clearance. Constant what? Elimination is constant in zero order. Clearance is constant in, yes, yes, Shipra, constant in zero. Excellent, excellent. Clearance in first order, very good. So, dono opposite hai. And the rest will change. Clearance, elimination. Elimination यहाँ पे it is proportional to the, elimination will be proportional to the plasma concentration. And clearance here is, what about clearance? Okay, we'll see. Clearance. Clearance. What happens to clearance in the zero order? Clearance in the zero order. Good afternoon. Good evening हो गया. Med Psycho. Good evening. चलो, clearance in zero order. No, clearance is not constant in zero order. Clearance is inversely, yeah, it is inversely proportional. Clearance is inversely proportional in zero order. Inversely proportional. Half life. So remember ये चारों चीजें. Please remember this. Zero order में, ठीक है? You remember one, the other is going to be opposite. ठीक है? So remember about first order, the other will be various. I know it is confusing, but remember first order and the other is going to be opposite. So remember first order, half life is constant. ठीक है? So remember half life is constant. So it will not be constant in the other. ठीक है? Elimination is directly proportional in first order. It will be constant in the other. If clearance is constant here, it will not be constant in the zero order. First हमेशा it's a very good kinetics. So you see the half, दो चीजें, half life और clearance तो आप याद कर लो. Half life clearance is constant. Half life and clearance is constant in first order. Remember this for first order. Opposite is true for the zero order. ठीक है? ये वाला आप you make this chart. Half life HEC. अगर सिर्फ ये तीन चीजें ही करनी है, it is constant, directly proportional and constant. ठीक है? ये तीन चीजें HEC. ठीक है? ये चीज याद रखो. Constant, directly proportional, and this is also constant. The ulta will be there for the zero order. Now what other thing is important here to know is this is the most or commonly followed kinetics. सबसे common, most commonly followed kinetics. ठीक है? And this is not common or rare है. So most of the drugs follow first order kinetics. So you don't have to remember the common things. Always remember the things which are not common. So the not common means which are the drugs which follow the zero order kinetics. So can you tell me the drugs which follow the zero order kinetics? Drugs which follow the zero order kinetics. Yes, one is warfarin. So there is a mnemonic, 0 watt power. Yes, 0 watt power bhi kar lo, because P is for phenytoin. So warfarin, excellent. ठीक है? A is for aspirin. T can be for even tolbutamide as well as the theophylline, right? Yes. And P is for phenytoin. Yes. Now, another question out of this. This is one important question. Which of, or A is also for alcohol. ठीक है? Now, which of the following out of these follows, let's say, true zero order kinetics? True zero order kinetics. Which follows true zero order. That means it follows it every time. Zero order ही रहेगा. Because most of the drugs in their therapeutic concentration, they follow first order. And when you go high, ये जो बाकी drugs है, then they start following the zero order. Yes, excellent Ankit and excellent Shipra. So, the drug which is your alcohol, true zero order kinetics. The rest are pseudo zero order. So, remember this also as an important question. Alcohol, yes, med psycho. Very good. Excellent, all of you. All right, so let's go to the third important. So, omeprazole is given to a patient of peptic ulcer, which is a non-competitive inhibitor of hydrogen potassium ATPase. Which of the following is true for the drug? Decrease Vmax only, decrease Km only, decrease in both Vmax and Km, and decrease in Vmax but no change in Km. Mithun says 4, Lubna says decrease Vmax, Chipra says 4, Ankit says 4, Dr. Shubham says 4, Med Psycho says D or 4, Sam 4, Adnan says 1, no change in KM. All right. Very good, very good. So let me, there's a mixed response, but here the correct option is this one. Decrease in Vmax, but no change in the KM. Because क्या हम बात कर रहे हैं? We're talking about non-competitive inhibition. So let's see what happens in non-competitive inhibition. Just a quick revision. Okay, so remember, this is the graph without any competition. So this is the response. This is the dose for the response. So the Km can be made accordingly. Now let's say we have given a competitive inhibitor. Okay, competitive inhibitor देते हैं. So they compete for the same site, right? Good day, Rishi. So they compete for the same site. That's what the competition means. Yeah, you compete for the same site and you want to reach to the same level. So you want to reach to the same height, same Vmax. Even if you have to work a little harder, that's the competition, right? So why are you competing? You want to reach that level even if you have to work a little harder. Okay? So the Vmax, when you have to reach the same level, the Vmax remains the same. The dose required to reach the Vmax, that is slightly higher. So Vmax, this is in case of competition, wherever there is competition. So in competitive inhibitors, the Vmax will eventually be the same. All right. So eventually be the same, the kilometer, yes. So you have to work a little harder, right? So the Km is going to increase, but Vmax remains the same. Kilometer बढ़ेंगे या you have to work a little harder to reach that same. Competition है भाई, काम तो ज़्यादा करना पड़ेगा. So that is what you have. So Vmax remains it. Now competition, let's say now we have a, let's change this color and have a non-competitive inhibitor. So non-competitive inhibitor ये है, even if you start with the same zeal, with the same force, but after a while you lose interest, ठीक है? So competition नहीं है. So the performance is going to go down. So the Km remains the same, but the slope decreases. The performance will go down because there's no zeal to compete. So there is decrease in the Vmax. The slope is going down. ठीक है, ये non-competitive है. But the Km is the same. ठीक है, so remember in competition, wherever there is a competition, you want to reach to the same place with a little harder work. So Km is going to go high and the Vmax, you will reach that if you study harder and work harder. A slightly more effort is required. So Km will be there. Okay? But non-competitive, the Km remains the same. Okay? You are at the same. But after a while, there is because there's non-competition, the zeal goes down basically. Competition ka spirit khatam ho gaya, and so therefore the performance is going to go down. So this is one way of the representation of a graph. Now the other way in which this graph comes about the competitive, non-competitive and another type of inhibition which is the uncompetitive. So that is given in form of the Lineweaver-Burke plot for enzyme inhibition. So what they give you is they give you any of the graph. So either they will give you this graph or they will give you this graph or they will give you this graph. And you will be asked to identify the competition or type of inhibition, whether it is competitive, uncompetitive and non-competitive. Okay? So competitive people always, they are going to cross paths. They are going to compete with each other. So remember in this, wherever there is an intersection on the y-axis पे जब intersection है, so that is competition. ठीक है, so they are going to compete, they are going to cross paths, लड़ेंगे आपस में. So there's going to be intersection. So this is for competitive inhibition. First, let's go to this. So in the non-competitive inhibition, this one is the non-competitive inhibition. Yes, they are going to do this. Yeah, cross, remember competition होना है तो ऐसे होएगा. Then coming to the non-competitive inhibition, as I said, starting तो करते हैं, बाद में they give up. No, रहने दो, we are not going to compete. So they start at this one point and then it's a V. So it becomes like a no, later on they go away from each other. So non-competitive, they start with the same zeal, but they end up not competing with each other. Like, छोड़ो यार, why should we compete? So that is non-competitive nature. while the uncompetitive होता है जब there is no competition का nature ही नहीं है, so हमेशा they will stay separate only, there is no way they are going to cross paths, so there is no zeal, nothing, right? So they are going to stay parallel to each other. So competitive, here you can say the competitive inhibition is going to be X, the non-competitive is going to be V, and the uncompetitive is going to be parallel. ठीक है, सी एक्स एन का वी होगा वी शेप्ड ग्राफ और अनकॉम्पिटिटिव विल बी पैरेलल. ये तीन, दिस इज कैन, इफ दिस ग्राफ इज आस्क्ड देन दिस इज द ओनली थिंग दैट यू शुड नो. ठीक है, because we already know this कि km vmax is already there, but what else is the shape of the graph that you can be asked to identify. So this is a very very important graph, has been asked before, so please note down this one, right? All right, U is parallel basically, so it's a parallel, it looks like a U if you can make like this, so it's parallel basically, they go parallel to each other, that is the important thing. ठीक है, all right. Now let's go to the another commonly asked topic, which is about your clinical trials. ठीक है, clinical trials, age old, important. Some one or the other questions asked sometimes. So let's do this. Comparison of efficacy of a new anti-epileptic drug with an existing drug is done in. Please always read the question very carefully. ठीक है? It is definitely efficacy, yes, but there is a word which is comparison. So a comparison of efficacy तभी होता है कि पहले efficacy has been established, already confirmed, and now you are going to compare it with an existing drug. ठीक है? So that is important. Yeah. So let's, so very right, two, no, it's not two, that's what I'm saying. Two is only to explore the efficacy. When you want to confirm, जब efficacy एक बार confirm हो गई एक drug की, now you want to establish or confirm कि yes. And how will you confirm? When you compare it with some standard drug which is already present there. ठीक है Lubna and Neeraj, right? So that is how you confirm is by the phase 3 trials. So this comparison will always be in this one, phase 3 trials. So let's briefly now also do some points about the phase of clinical, just clinical trials, something briefly what you should be knowing. The phase 0, okay, is microdosing. It is microdosing means very small, therapeutic bhi dose, very small dose is given, 100 kai bari, and very small population. In very small population, but who are those people? They are healthy volunteers. They are not diseased people. They are healthy volunteers, right? There's no question of blinding here. Okay, so blinding is not required here. The aim, no, animal studies are different. Those are preclinical trials. This is a part of clinical trials, but this is not yet very common. Phase 0 is not very common yet. But what is the main aim? Why they want to introduce this phase 0? So that they basically want to know about the pharmacokinetics beforehand, especially the bioavailability. Okay? So bioavailability they want to know. So sometimes the bioavailability features or the kinetics are not very, let's say, suitable for the human. So you have to go through the expensive phase 1 trial, spend money and costly hai, waste ho jate. So initially you want to confirm with small dose whether the bioavailability or the pharmacokinetics is suitable to these to the human जिनमें हम try कर रहे हैं. So it is just to try the or find out about the bioavailability. So that is the main aim of phase 0. If you're asked, the aim is just to know about the information about the kinetics, especially bioavailability. That's the whole aim of phase 0. Now phase 1. Phase 1 is human pharmacology and safety. The name is human pharmacology and safety. And again, it is done in healthy human volunteers. Right? Healthy human volunteers. And what is the number here? Important, very few, 20 to 80. No blinding. There's no blinding here. The main aim of phase 1 trial, the main aim is to know about the maximum tolerated dose. The main aim is to know about the maximum tolerated dose, and then you can, अगर option आएगा, if option में ये सारी चीजें हैं, you have to mark the maximum tolerated dose. That is the main aim. And then the safety and the kinetics, then they also come into picture. The second phase is therapeutic. So you are exploring the therapeutic efficacy of a drug in this. Okay, so you are exploring first. So इनमें explore किस में करेंगे efficacy? Obviously efficacy cannot be done in healthy, जिसमें disease ही नहीं है. Where there is no disease, you can't determine the efficacy. So efficacy can only be determined in patients. So this trial is done in patients. Right? This trial is done in patients. So about 100 to 500. It's a small number of patients and in about 2 to 4 centers. Okay? 100 to 500 would be the number of patients and in 2 to 4 centers. And blinding, yes, it can be either a double blind or it can be open label where there is no blinding. The main aim is here, as we discussed here, it is the efficacy. It is the efficacy. Okay? The third phase, which is now on a wider number of patients, more number of patients. Okay? Explore. Now we know, we have found out about the efficacy. So you see here, this trial ka name only, if you see, here I will write this. It is confirmation of the efficacy and comparison. So see, comparison studies जो भी आएंगी, that will automatically be a part of phase 3 studies. Okay? So here the number of patients, again, they are going to go up. It can be as large as, yes, pre-existing or standard drug that we say. जो standard drug है, उसके साथ we are going to compare the efficacy. So 500 to 3000 and it's a multi-centric trial. Okay? And most of the times these are your double blind. Most of the times these are your double blind. Okay? So this is again to determine the, or confirm the efficacy. Determine होगी और इसको confirm करेंगे efficacy with the existing therapy. So we are going to confirm it by comparing it with some existing therapy or existing treatment, whatever is available. So safety भी मिलेगी और इसमें भी have chance to study because it's a wider scale, wider number of patients. So some amount of safety studies or the safety data can also be gathered. But ज़्यादातर safety data is a part of the phase 4 trials. So after these phase 3 is over, now the new drug application is submitted. So when is the new drug application submitted? After phase 3. Because now is the time for the drug to enter into the market. Yes, very long period. Yes, it is actually for years, long years. So now it comes into the general population. जो भी और doctors and जितने भी healthcare professionals, they will all start now prescribing this drug which is there now. So when they start prescribing, so there's no blinding की ज़रूरत नहीं है because it's openly you're prescribing, patient is coming to you and you're prescribing the drug. And what here matters is your ADR monitoring, everything is very important during this phase because now you're gathering data to know about any unknown side effect because now the population is huge. So you can even know about the unknown side effects जो पहले we could not come to know because the population was small, or some rare side effects can come, right? Or long-term side effects. Because now it is into the population as whole and even in the population groups, for example, in pregnancy and all those special population groups also, we can come to know about their effects. Special population groups. So all these are actually a part of, all these are a part of the phase 4. So these are the most important, yes, any other use also, all these are the most important. But agar if you are, suppose पूछा जाए तो basically it is your, and where, in which trial is the ADR monitoring done, in which of the phases is the ADR monitoring done, or pharmacovigilance studies are done, in which would be done, in which phase do you think? ADR monitoring अगर आए post marketing surveillance, it would also be done in the phase 4, right? Phase 4. No, phase 4 ADR monitoring is phase 4. Phase 2 is not ADR monitoring. Phase 2 में तो अभी हम maximum tolerated dose निकाल रहे हैं, ठीक है? So ADR monitoring तब होएगी कि the drug is out into the market and now we are observing, जैसे ADR forms collect करें कि कोई problem, if any patient has had a problem and they will report to the healthcare professional and we are going to monitor and report it. That's how we collect data that maybe this drug is causing this because it's now in a larger number of population and for longer time. So these are the brief things that, yes, phase 4. So these are the most important things of the phases. That's, I think, more than enough for you to know. Right? All right. Now coming to the next part, the next question here. Which of the following is wrongly matched here? So basically this is about a drug and the antidote. Which of the following is wrongly matched here? Shipra says D. All right. So she means cyanide and vitamin. Dr. Shubham says 2. Sned says 4. Dr. Raj says 4. Sam says 3. Neeraj says 4. All right. Yes. The correct option is yes, bilkul. Cyanide and vitamin B6. See, जिसने बेगोन is like they contain organophosphorus compounds. Okay? So they contain organophosphorus compounds. So atropine is an antidote for organophosphorus compounds. So don't get confused if they put this instead of directly writing organophosphorus. Okay? So cyanide, yes, as vitamin B12, yeah, hydroxycobalamin and amyl nitrite with sodium thiosulfate also. So now we are going to discuss about the important drugs and the antidotes, and rather you're going to tell me and I'm going to simply write. So let's start with organophosphates or carbamates. Yes, quickly you are telling me what is the antidote for the first one. Organophosphate carbamate. Jaldi, let's revise. ये revision है, so फटाफट. Very good. Atropine. Okay, इसमें एक और question I'll ask you before we go to the next. Pralidoxime can be given in both organophosphate and carbamate. One by one. पहले बताओ. PAM can be given in both organophosphate and carbamate. Atropine plus, no, अगर antidote में question आएगा ना, so if you are given both, you have to mark. अगर atropine अकेला पूछा गया, you please mark atropine. Atropine is the first thing. जो होते हैं anticholinesterase reactivators, they are secondary. First is atropine always. Yes, PAM only in organophosphates, not in carbamates, because there is no site left in carbamate poisoning for the pyridoxine to act. Yes. All right. Let's go to the next one. Datura, belladonna, ya atropine. All the same. What is the antidote? Many of you gave me the answer, but still, let's see. Neostigmine is not the answer. If you've given, okay. Physostigmine. Yes. It is physostigmine. Tertiary compound होना चाहिए. Digoxin. Very good. All of you. Yes, Adnan, Dr. Shubham, Lubna. Yeah, that's. ठीक है. Digibind. Excellent. Adnan. Excellence ने. It is Digifab, Digibind, whatever comes. ठीक है. Digibind, Digifab जो भी आएगा. Both of them are correct. ठीक है. Beta blockers. Very good, Dr. Pio. Very good, Dr. Shubham. Beta blockers. Jaldi. Beta blockers. Very good, Dr. Shubham. Shepra, Sneh. Excellent. You should give yourself a pat on the back, all of you. Excellent. Beta blockers, glucagon. Benzodiazepines. Flumazenil. Excellent, Dishant. Excellent. Flumazenil. Shabash. Flumazenil. Lubna, Snej, Neeraj. Very good. Morphine. Naloxone, excellent, naloxone. Great. Methanol or ethylene glycol? Methanol or ethylene glycol? Ethanol की जगह, okay, one option is ethanol. What about the other option? Fomepizole, excellent. So this has to be preferred if it is asked in exam, ठीक है? Greater than, ज़्यादातर mark this if both are given. Usually they will not give together, but if they are given, please mark fomepizole. Tricyclic antidepressants or salicylates? Tricyclic antidepressants, salicylates. Very good. Sodium bicarbonate. Sodium bicarbonate. Paracetamol. Very good, very good. Paracetamol. No, paracetamol naloxone nahi. N-acetylcysteine. Yes. N-acetylcysteine. Very good. Few more to go. Heparin. Few more to go. Heparin. Antidotes fingertips पे होना चाहिए. Antidotes, there is no excuse for you not to know. ठीक है? So it has to be on your fingertips. Protamine sulfate. Excellent. Protamine sulfate. Very good. ठीक है? Warfarin. Vitamin K. Excellent. Vitamin K. Very good. Initially क्या vitamin K ही लिखोगे आप पहले, ठीक है? Okay, apixaban, rivaroxaban. This has been also asked. Apixaban, rivaroxaban. Very good. Andexant alpha. XA, 10A, factor 10A. ठीक है? Very good. Dabigatran. Very, idar. Yes. Idarusizumab. ठीक है? Idarusizumab. No, adalimumab. Idarusizumab. ठीक है? Cyanide. अभी हमने किया हाइड्रोक्सो. स्पेलिंग आइदारू सी. ठीक है? इदारूसी लिखने की कोशिश करो, यू विल रिमेंबर. ठीक है? हाइड्रोक्सोकोबालामीन. ठीक है? और देन वी यूज नाइट्राइट्स लाइक amyl nitrite along with sodium thiosulfate. ये सारा आप लिख सकते हो. ठीक है? methotrexate. Folic acid, folinic acid, yeah, or leucovorin. Excellent. Arsenic या mercury? Arsenic या mercury? All right, yes. Dimercaprol. You can write the name. Right, bad. All right. So ये है. These are the few important. You can say the antidotes, and this, as I said, have to be on your fingertips. You cannot afford to mark them wrong in the exam. ठीक है? इसका कोई excuse नहीं है. And they have been asked 1 or 2. Usually, हर exam में they have been asked. So I think you all of you know most of them. ठीक है? So I'm very, very happy with that. Yes, let's go to the next question now. Another very commonly asked question. ठीक है? Match the following anti-glaucoma drugs with their ocular side effects. ठीक है? Again, very, very, very important. Anti-glaucoma with their ocular side effects. Okay, let me go one by one. ठीक है? A का, what is the A? Adrenaline का, which was the side effect of adrenaline? A का 2, yes, very good. A is 2. Latanoprost, B is, yes, very good. B is 3. Aproclonidine, C is lid retraction. Letarsodil रह गया, so you can make out this is your conjunctival hyperemia, और अगर red eye भी लिखा होगा, that's also for letarsodil. ठीक है? Yes. Great. Alright, so let's go to the important adverse effects of drugs used in glaucoma. Timolol is stinging in the eye, and it can lead to blepharoconjunctivitis, as well as it can precipitate asthma. So अगर bronchial asthma का patient है, we don't prefer to give timolol, right? Latanoprost. So these are two images. If the sometimes the adverse effect is not asked in the text form, they give you an image and say identify the drug causing this. So the first image here is, you can see the pigmentation of the iris. Iris is pigmented. And this can also be asked, yes, aggravates, okay, exactly, precipitates, I said. It is heterochroma iridis. ठीक है, heterochroma iridis or pigmentation of iris is a feature of latanoprost. The second important side effect, as you can see here, is growth of eyelashes. So growth of eyelashes, and this is called as, and growth of eyelashes, hypertrichosis. ठीक है, that can also be asked, growth of eyelashes. This is the number 1 side effect. This is the number 2 side effect, and the number 3 side effect is your macular edema. ठीक है, growth of eyelashes, so it can cause hypertrichosis or growth of eyelashes, heterochroma iridis, iris is pigmented here, and the third one is your macular edema. So ये 3 important side effects of, so this one, ठीक है. Adverse effects of apraclonidine. Apraclonidine का main adverse effect is your lid retraction. One of the most important is lid retraction, and it is contraindicated in children less than 2 years. Why? Because it can lead to apnea. ठीक है, apnea, and CNS depression and apnea in the newborn and neonates especially, so contraindicated in children less than 2 years. Acetazolamide can also lead to corneal edema. ठीक है, corneal edema, acetazolamide. Nitarsodil, it's a newer drug, so must know that it can lead to conjunctival, हमने ये याद रखना है क्योंकि न्यू है ना, hyperemia और redness in the eye, red eye. So nitarsodil is conjunctival hyperemia, remember. Or epinephrine, it causes pigmentation of the conjunctiva. So pigmentation, please read carefully. If it is the pigmentation of the conjunctiva, the answer is epinephrine. If it is pigmentation of the iris, your answer becomes latanoprost. Don't confuse between the two, whether it is asked iris or conjunctiva. So the difference would be accordingly. Right? Okay. Now, let's do briefly even the mechanisms. कि कौन सी drugs, what do they do? Which are the drugs which cause increase in the uveoscleral outflow? So remember the prost drugs, जो भी prostaglandin and prostaglandin, the prost drugs are going to increase the uveoscleral outflow. Drugs increasing the trabecular outflow, PPN, ठीक है, trabecular outflow is PPN. Pilocarpine, ठीक है, physostigmine and even Detarsudet, PPN, right? Now drugs which cause decrease in the aqueous formation, A, B, C, D. Apraclonidine, brimonidine and like drugs. B से क्या आएगा? Beta blockers, timolol, bitoxolol. C से carbonic anhydrase inhibitors, and you can remember even dipivefrin. Right? So remember, even dipivefrin has been shown to ये भी decrease करती है aqueous formation. So you can remember these. So these are important. Which drug increases the uveoscleral? एक ही है, prosts, and then the trabecular outflow and the aqueous formation. Right? So these are the important points we have discussed about the the drugs used in the glaucoma. Okay? And the drug of choice, you know, all of you know the drug of choice. In open angle glaucoma, drug of choice. कौन से हैं drug of choice? Very good. The prostaglandins, latanoprost like drugs. Excellent. All right. Yes. Yes, Shubham. Yes, Shipra. Very good. Now this question, the prosts are the drug of choice. Okay? Now the drug recently approved to be used along with phentermine in the management of obesity is. Excellent, Jitain. Excellent, excellent. Great response. Yes, it is topiramate. Very good. Topiramate has been used along, approved हो गया है to be used along with phentermine. ठीक है? Now, इसमें again, let's do the drugs. आपको नाम you should know. There's nothing more to remember in this but the names of the drugs. GLP-1 analog सबसे पहले, the most important. You will remember 2 semaglutide and liraglutide. ठीक है? So these are the first drugs that we use, semaglutide and then liraglutide. Then we have your oral lipase inhibitors. Orlistat is one, ठीक है? Cetylistat is the other. All the stats, oral lipase inhibitor stats, orlistats, cetylistats. And then if they are not effective, we go with the combination therapy. And ये जो combination recent है, एक phentermine and topiramate. The other one is ibupropion with naltrexone and also bupropion with zonisamide. ठीक है? ये भी combinations हैं. And which ones we don't use now? Sibutramine, fenfluramine. So why we don't use them? What is the reason for not using them? What is the reason for not using them? They are cardiotoxic. ठीक है? Cardiotoxicity है reason, so we don't use them. ठीक है? Alright. So ये कुछ some of the drug combinations, you don't have to remember all. So if you can, cardiotoxicity, Dr. Shubham, ठीक है? So these are some of the drug combinations which are used in the management. You can just take a snapshot so that you know कि ये use होते हैं. ठीक है? In case they ask you. Nothing, उसमें details you're not required to know. They can just ask you the combination. And because obesity के लिए इतना ही बहुत है. That is nothing much more is required here. Okay. ठीक है? Now, let's go to the next question quickly. So paradoxical bronchoconstriction with ipratropium is seen because of all except. This was a recent INICT 2021, I think, question. So what is the option here? 2. Okay. Neeraj says 2. Okay. Sam says 3. All right. Jitin says 3. Dark Knight says 4. NEET PG 4. Oh, Bayan says 3. All right. So जो correct option है, hypotonic. Maybe there is an error here. So the option is, correct option actually is presynaptic M2 stimulation. ठीक है, presynaptic M2 stimulation. Now why is this the correct option? Why do you think is the correct option? अगर stimulation होगा, what should happen? So you know यहाँ पे yes, we have actually यहाँ पे तो M3 receptors present होते हैं. But when we are talking about the presynaptic, ठीक है? So यहाँ पे acetylcholine है, and here we have the presynaptic M2. So always remember, these are your autoreceptors or presynaptic receptors. Yes, whenever M2 is stimulated, and you know when the autoreceptors are stimulated, they are going to lock this gate. So when the gate is going to be locked, the acetylcholine is not going to be released. And the bronchoconstriction क्यों हो रहा है? Because it is the cholinergic activity. So that's why you're giving anticholinergics here. So whenever M2 is stimulated, the acetylcholine is not going to be released. So basically, it was going to not cause the bronchoconstriction. But when you inhibit M2, the lock is going to open and the acetylcholine is all going to come out, and that will lead to bronchoconstriction. So अगर यहाँ पे the option had been inhibition, then it would have been correct, but stimulation does not lead to the response, the bronchoconstriction. Right? So clear here, right? So here M2 autoreceptor का फंडा we all you know, ठीक है? Presynaptic, yes, they're always inhibitory. It's like a lock on the door. जब lock को हम stimulate करते हैं या लगा देते हैं, so nothing can come out, ठीक है? And when you inhibit, अगर आप खोल देते हो, तो everything can come out. So it's as simple as, so it is just like a lock on the presynaptic neuron. You can say that, right? All right. Now this is another important question जो भी आया है, and please go through this. So this is an HIV positive woman on ART was prescribed ergotamine for a migraine attack. Okay. After a few days, she presented with complaints that she's unable to feel her legs from mid-thigh to her toes for the past 2 days, and the angiography image is shown. So what is the diagnosis? Very good. Already given कि ये ergotamine है, दिया हुआ है for migraine, and if you see here, there is decrease in the perfusion, ठीक है? So that means there is vasoconstriction, and vasoconstriction about, so vasoconstriction क्या होता है? Vasoconstriction is because a feature of ergotamine. So this is called as ergotism. ठीक है? This is about ergotism, and this is actually the ischemic necrosis. ठीक है? This is about the ischemic necrosis here. So we will just quickly go through the ergot alkaloids here. So these ergot alkaloids होते क्या? This is because a crop, that is your rye or millet and all, and they have the fungus here. This is the ergot fungus, Claviceps purea fungus होता है. So people who eat this without clearing or cleaning it, they will get the ergot. So वो जो cause करता है, that's called as ergotism. ठीक है? So they are potent vasoconstrictors, you know, that's why they are used in migraine. ठीक है? So they are used in migraine, they are potent vasoconstrictors, and this vasoconstriction is important migraine, but the reason why they are not preferred now triptans have come up is because that they cause a lot of nausea, vomiting. Already migraine mein nausea, vomiting hota hai, and they in addition cause nausea, vomiting. That's why they are not preferred, and they are very dangerous, very potent vasoconstrictors. And their side effects are they can cause rise in the blood pressure. So they're absolutely contraindicated in people who have hypertension. Okay? So then we have angina can be precipitated. So patients who already have a history of a myocardial infarction or angina, again contraindicated in those patients. Then they can lead to peripheral vascular disease. So Raynaud's disease वगैरह में absolutely contraindicated, ठीक है, because they are potent vasoconstrictors. And this is what happens because of the vasoconstriction of the periphery or the peripheral digits. There is ischemic necrosis called as ergotism. ठीक है, ergotism है. So ये आपको features, if this is shown alone, so you can easily see that this is because of the ergot alkaloids. ठीक है. So now quickly about the drugs used in the migraine. Which are the drugs used in migraine? Acute attack. Mild to moderate में कौन सी drug use करते हैं? Quickly. Mild to moderate. Mild to moderate. Which is the drug? NSAIDs. Excellent. NSAIDs. ठीक है? Very good. Mild to moderate NSAIDs. Severe attack. Drug of choice. Acute attack. Severe acute attack. Drug of choice. Triptans. Very good. Triptans, because they cause action is on 5-HT1D 1B, leading to vasoconstriction as well as inhibit the CGRP release. ठीक है? Coming to the prophylaxis. Prophylaxis में A, B, C, D याद रखेंगे. A, B, C, D. A stands for anti-epileptic drugs. कौन सी anti-epileptics यूज कर सकते हैं? Valproate, topiramate, gabapentin. Valproate, topiramate, gabapentin. Valproate, topiramate, gabapentin. ये तीन यूज कर सकते हैं. Beta blocker, drug of choice for prophylaxis. Drug of choice for prophylaxis is beta blocker, propranolol. C, calcium channel blockers. 1. Which one? Flunarizine. ठीक है. Another C, एक और C है CGRP antagonists. Which are the CGRP antagonists? This was a question used in migraine. CGRP antagonist. Yes, G-PANs. Okay, very good. G-PANs. Monoclonal antibodies कौन सी? Against this. Monoclonal antibodies against. Which are the monoclonal antibodies which are used against here? It is erinumab. Erinumab. Yes, very good. Erinumab, and then there are two Zumabs. Yes. Free Mani Zumab. Gal Kyani Zumab. दो Zumabs हैं और एक Umabs है. ठीक है. So ये है monoclonal antibodies which are used for the migraine. Yes. Erinumab already question has been asked before. So these are two newer drugs जो अभी आई है for the acute attack. ठीक है. One is your Zavegepant. इसलिए because I'm telling you this is very new and it has come as a nasal spray for acute attack. Zavegepant. ठीक है. And the second one is Lasmiditan, is another drug which is a 5-HT1F. 5-HT1F agonist. 5-HT1F agonist. And this also causes a decrease in the CGRP release and vasoconstriction only in the cranial blood vessels. It doesn't lead to vasoconstriction in the periphery. ठीक है, so that is its advantage over the 5-HT 1D 1B. ये cranial में ज़्यादा effective है, the vasoconstriction, therefore no peripheral vasoconstriction. So this is another new drug. So these two drugs you must know. ठीक है, newer drugs हैं, especially ये वाला, because ये very very recent drug है, right? All right. Okay, let's come to the last question of today is about digoxin. Again, some ये topics कुछ ऐसे topics है that you are not supposed to miss. Hopefully it should not have, because अब once it comes into the market, let's see what effect. That's the reason periphery जो इतने भी side effects है vasoconstricted, it shouldn't be there. ठीक है, but what happens is when the drugs comes into the market, triptans contraindicated, same vasoconstrictor है ना, you should not give them in patients who have myocardial infarction, who have hypertension. Another thing, triptans, it is for both. You can ask newer drug से कहीं भी पूछ सकते हैं, ठीक है, so it can be asked anywhere, and because जो भी exam nearby होगा, so newer drug will definitely be there, right? तो इसको definitely ये new drugs you should know. ये सारी जो questions है, they are a mix and they have been asked everywhere, ठीक है ना? तो आप ये जो questions है, इसको चाहे you forget about which exam, this is must know for everybody, whether you're FMG, whether you're NEET PG aspirant, whether you are appearing for an INI-CET, must know. All right, let's go to the digoxin. Digoxin, as I said, no, you cannot go to an entrance exam without knowing about digoxin, at least the important salient features, ठीक है? चलो, which of the following are true about them? These digoxin. True, false, true, true. Okay. Lubna says 1 true, second false, 3 true. But there are 4. Fourth option किसी ने नहीं बोला? Fourth option. Okay. 4 true. Okay. Sam says 4 true. 4 true means only fourth true ki all true? 4 true. Okay. All true except 2. Alright, alright. Chalo, let me tell you now. So the answer is that all are true. कोई false नहीं है इसमें. ठीक है? So this is just a trick here. Yes, yes. Xanthopsia is seen with. All are true. All are true. Yeah. ये भी true है, ये भी true है, ये भी true है, ये भी true है. So let's see. ठीक है? Earliest manifestation is GIT side effects. So let's हम ये करते आगे. I will tell you first. Let's go important points for digoxin. Then we will come to this. ये digoxin toxicity. ठीक है? So ये digoxin toxicity है. ठीक है? ये हमने पहले भी किया था जो सेकेंड स्लाइड में कि ये आपको लेवल्स यू शुड नो कि ओवर 2 इट विल बी अ टॉक्सिसिटी. बट यू सी व्हाट हैपेंस इज समटाइम्स द थेरेपेटिक रेंज में होके भी देयर कैन बी टॉक्सिसिटी. सो द थेरेपेटिक रेंज इज नॉट, इट विल नॉट ऑलवेज बी कोइंसाइडिंग विद द toxicity symptoms because there are so many factors. Otherwise what they say is like, see, digoxin is usually given in patients of heart failures. They'll be on other drugs, especially diuretics. So diuretics का tendency क्या होता है? They cause electrolyte disturbances, hypokalemia especially, and they can make these toxicity symptoms appear even in the therapeutic range. So it is not always that digoxin toxicity will correlate with the therapeutic range. So remember this. हमेशा ऐसा नहीं होगा कि हाई है तो ही टॉक्सिसिटी होगी. सो यू हैव टू मॉनिटर दीज पेशेंट्स अकॉर्डिंग टू देयर सिम्टम्स rather than only going by with their blood level. So symptomatic treatment and symptomatic follow up is more important in case of digoxin. ठीक है? So remember this. So इसीलिए ये मैंने दिया कि early toxicity it may not always correlate with the serum levels. Even when you think the levels are in this, ठीक है? So in this you can see here, right? Let's do this. The earliest and the most common symptom. Earliest and the most common symptoms. Please tell me the earliest and the most common. I'll come to that. So nausea, GIT, nausea, vomiting. Earliest and the most common is nausea and vomiting. Most common arrhythmia. Most common arrhythmia. Yes, earliest in this. Most common arrhythmia. Ventricular bigeminy. Very good. It is the ventricular bigeminy. ठीक है? Vision defect. Vision defect. Yes, vision defect. Set. Xanthopsia. Yes. Xanthopsia. Okay. Next is treatment of ventricular arrhythmia. Ventricular arrhythmia. Treatment of ventricular arrhythmia. Lidocaine. Lignocaine. Very good. Very good. Very good. Lignocaine. Lidocaine. ठीक है? Atrial arrhythmia. CCBs. Atrial arrhythmia. No, atrial arrhythmia. फिब्रिलेशन वगैरह अगर होएगी तो कौन सी देंगे? नो. Atropine is given here for the block. Beta blockers you can give. ठीक है? Severe toxicity you have to give the antidote. क्यों? Severe toxicity के लिए you need the antidote. And जो हमने किया antidote is digibind or digifab. Severe toxicity में. ठीक है? Now, dash increases the toxicity. So I want to ask you which are the electrolytes increasing the toxicity. Dash जो electrolyte imbalance which can increase the toxicity. कौन से electrolyte? Hypokalemia. Hypokalemia, yes, hypokalemia. Hypercalcemia and hypomagnesemia. Excellent. Hypomagnesemia. ठीक है? Hypomagnesemia. And because digoxin has a long life, you know that digoxin has a long half-life and उसकी cumulative toxicity भी होती है, so we have to give it 5 days every week. ठीक है? So that is another reason here. Yes, because obviously you're using a diuretic, you have to use a diuretic when we are treating heart failure patients. तो ये जो है they will definitely come into picture. ये electoral imbalances are going to come into picture. So therefore, this is the problem which can arise. So you have to monitor it very closely. That's what I said कि because the concurrent therapy is a diuretic, हमेशा we can only not rely on the serum levels to see whether the toxicity is going to come. अभी therapeutic है, so we are safe. No, so you have to rely on the symptoms of the patient rather than just the treatment. Okay, should we end here or one last question? Let me see. Should we end here or one last question? देखते हैं if you are still ready for one last question. One more. ठीक है? ये one more. Just one last question. All right. ये एक important question again. This was asked अभी recently in the not recently, I think 2021 again in ICT. ठीक है? Continuous inhalation of nitric oxide is used for. Option. Dr. Shubham says 4. Okay. 4. Very good. D4. शाबाश, और excellent, all of you know this answer. So pulmonary hypertension, ठीक है? So this is the continuous when you give therapy. So who will tell me the other drugs which are given for pulmonary hypertension? Other drugs given for pulmonary hypertension. बता दो कौन सी दे सकता है इनमें से. चलो लेट्स सी नेम्स ऑफ द ड्रग्स. वेरी गुड. CCBs पहले. यस, यू ऑल नो CCBs. वेरी गुड. एम्लोडापिन, निफेडापिन. ठीक है, एम्लोडापिन, निफेडापिन. एंडोथेलिन एंटागोनिस्ट, ऑल सेंटेंस, बोसेंटिन, एम्ब्रीसेंटिन. ठीक है, वेरी गुड. PDE5 inhibitors is sildenafil. ठीक है, tadalafil. Soluble guanyl cyclase activator, इसका नाम soluble guanyl cyclase activator. रियोसीगुएट. ठीक है, रियोसीगुएट. वेरी गुड. प्रोस्टासाइक्लिन्स, इपोप्रोस्टिनॉल. ठीक है, हाँ, इलियोप्रोस, टीप्रोस्टिनिल एंड ILIO, इलियोप्रोस्ट. ठीक है, इलियोप्रोस्ट इनहेलेशन देते हैं, इलियोप्रोस्ट. प्रोस्टासाइक्लिन रिसेप्टर एगोनिस्ट, प्रोस्टासाइक्लिन रिसेप्टर एगोनिस्ट. Selexipag, Selexipag. Prostacyclin, PGI2 receptor agonist is Selexipag. Yes. So ये सारी drugs हैं. Note them down कि इसको, this is something you should know. Any of the drugs, अगर इस बार continuous nitrochloride inhalation आया, इसमें से कुछ भी they can ask you. So these are the drugs which are used for management of pulmonary hypertension, and the drug of choice is here. So you're not supposed to know the details here, but here just this is a graph which is showing ki how to go about treating a pulmonary hypertensive patient. Initially what they usually recommend is that you start with a vasodilator or a CCB therapy, and agar responsive nahi hote hai, and then whether it is grade 2, grade 3, grade 4, and then. So here you see that we give especially the endothelin antagonists along with this phosphodiesterase 5 inhibitor. And आजकल there's a combination available of these two together. So ये है कुछ treatment modalities. You don't have to remember this. It is just to tell you for your reference कि this is how the treatment goes about. So only thing remember that ये जो है endothelin antagonists, these are your important drugs and drugs of choice currently. And yes, so this is, and the phase 4 में we prefer to give your only prostacyclins together. So ये है एक, you can take a snapshot कि this is important, that this is what is done. But I will not advise you that you have to go through everything. But ये आपको drugs पता होना चाहिए कौन सी देते हैं. That I have given the list of the drugs. That is most important, right? All right. So with this we come to the end of today's session. I hope you could revise the important points along with me. ठीक है? So those whoever is appearing nearby, they all must be already geared up, and this is just a quick revision. And those who have exams maybe later on, so they can take down that these are the important points that you cannot afford to miss. The primary aim is here to tell you these questions because that you cannot afford to miss these questions. So मतलब इनको पढ़ के ही जाना है. ये मैंने पढ़ा, और इसलिए जो जो पूछा गया है ये सारे का सारा एक एक चीज़ जो पूछी गई है ऑलरेडी एग्जाम्स में आई है. सो प्लीज़ go back, and if you go back to the recording, at least try and make notes wherever you're making notes and add these points. If they are there with you, well and good. If they are not there with you, just add these points onto those notes and you will be good to go. All right. So thank you so much, everyone. Take care. Have a great evening. Study well, study hard, be on track always, and I'll see you next time.